Can you, I think somebody's mic is on. Right. Welcome all of you to the second session of the orthopedics. Today, I think Ajit Tukkatarachi sir has already joined us for this session. I think Bandhujiva sir is also on the way. So without further ado, I think we can start, sir, right?
Yes, we may start now.
Yeah, okay. Last time we did the upper limb important common cases, common orthopedic cases. Today we are going for the lower limb. So students, who is going to be the candidate here?
I'll be answering this.
Your name is Puta?
I'm Chanuka.
Ishang?
Chanuka, sir.
Chanuka. Ajit sir? Hello, Ajit sir.
Ajit is in the participants list, neither.
Yes, he's there.
Ajit, can you hear me?
Yes, I can hear you.
All right. Shall we start now?
Yeah, we will.
Okay, so you can ask questions from the candidate, Dr. Chanuka.
Chanuk. Chanuka, what can you see on this X-ray? Can you please describe the first X-ray?
Yes, sir. This is a X-ray pelvis anteroposterior view with the bilateral hip joints shown in the X-ray, and I see on the left side a basal fracture, partially displaced, a complete basal fracture, partially displaced. So I'd say it's a garden 3 fracture.
Okay, so why do you say it's a basal? So what are the 3 areas you normally see in the neck?
Subcapital, cervical, basal, and extracapsularly you get subtrochanteric.
No, intracapsular you see subcapital, cervical and basal.
Yeah.
So what do you mean by cervical?
Across the anatomical neck of the femur.
Yeah, I understand it. Yes. So what do you mean by subcapital?
Just below the head of the femur.
Just beneath the head, yeah. So what do you mean by basal? It's almost at the level of greater and lesser trochanteric line, correct? That is a basal line there. Okay. So this one I would rather say it's a cervical. Do you agree or not?
I agree, sir.
Anyway, so you said, why do you say it's garden 3?
It's not completely displaced.
There is some contact with okay.
Yes, sir.
So yeah, what else you can see on this X-ray?
There's a symphysial widening.
Yeah, possible. Yeah, what else? Pelvis is tilted or not?
It's tilted.
The obvious is you can see. So for the reason for this tilting and other things we can find out later. Anyway, what are the clinical features of this patient? Dr. Pinto, do you know the age and other things of this patient or not?
No, sir. No, we don't know.
Oh, that's okay. So tell me, so just give me a clinical description of this kind of patient. So we are going in a reverse direction. Normally we should see the patient first and take the history examination and then we go for x-rays. But in this case, we have seen the x-rays, so we'll go reverse. So in clinical picture, what kind of patient normally do you expect?
So the patient can be a elderly patient.
Usually
with,
elderly patients, yeah.
Yes, sir. Or otherwise, if a young patient, can be after a trauma like a RTA. And elderly in the elderly population, you'd find someone with a bone weakening disorder like diabetes, so osteomalacia, osteoporosis.
According to this X-ray, do you think this is a male or a female patient?
This is a female.
So this is a female patient. What do you think in this case? Maybe a very elderly patient, or maybe not. So how? What do you predict? Normally, the history is in an elderly patient. You get it beyond 60s or whatever. But this, what do you think about the bone quality of this patient? From the X-ray, bone qualities, I would say bone quality is not too bad.
Yes.
The cortices are well marked, and I mean, X-ray wise, there's not much osteoporotic features shown here. So possibly relatively young, but we don't know. I mean, I'm just predicting. Maybe relatively young, maybe in 40s or something. But anyway, it can be even in elderly patients. Also, but I'm just asking from the available information on the X-rays. Okay, so this may be a female patient, maybe elderly or little younger. And what is you say clinically?
So the patient will present with pain and a shortened limb that is externally rotated.
Yes, pain will be there. So there may be a history of fall or something like that. Maybe something like that. And then there is pain in which area is the pain? Where do you get the pain in this patient?
Hip and thighs.
Hip and upper thigh, or maybe in the gluteal area, you can get the pain. And examination wise, as you said, it's externally rotated. Yeah, that's
and,
right.
Reduced range of motion.
That's correct. Okay. And what about the length of the limb?
It's shortened.
Maybe short. Okay. So those are the clinical features. And how are you going to attend to this patient? Now the patient has come to the emergency department and she had a fall and the leg is externally rotated. And what would you do in the emergency department?
So I'd first want to exclude the internal hemorrhage. So I'd want to resuscitate the patient and give
anyway, I would rather accept that if you go with ABC and if there are problems with hypovolemia or something, you would say it. But in this kind of cases, normally they don't need resuscitation. I'm just telling you, unless they have multiple injuries, this fracture neck of femur, unless otherwise they come with the pain. So anyway, so resuscitation, but we'll leave aside that one. What will you do? So specifically for this patient?
And give adequate analgesics. And after obtaining
you adequate analgesics, I accept it. And then what did you do?
After getting the X-rays, I'll decide on a definitive management. and the management I'm going to consider according to the
Before
patient's-
the definitive management, the patient is in pain and he can't move it this way or that way. We have to transfer the patient from one place to another place. So what would you do for that one?
I'd use a splint to immobilize the limb.
Okay, you can use a splint. So what kind of splint is suitable in this kind of patient? So patient's leg is rotated externally. So you can use either a non-rotation boot so that you can correct the rotation, and it also gives you immobilization. So that is called plaster of Paris non-rotational boot. You can use that one, or otherwise what can you use? Sometimes some people can use skin traction as a temporary measure to reduce the pain as well as to maintain the length of the leg. Okay. Okay. After immobilization, then
I'd go for according to the patient's age and the displacement. I will and the location of the fractures. I'll consider the definitive management.
yeah, we'll decide on the definitive management. In this case, we don't ask you what is the definitive management at your level, but anyway, I would say this patient needs surgery. So the surgery, so we have to do it sooner the better. Why we have to do surgery sooner in this kind of patient?
So this is a intracapsular fracture. So since the blood supply to the head of the femur is from mostly from the ascending artery, there can be vascular compromise. And
anyway, this case is an intracapsular fracture. So there's no question about the vascular supply. Anyway, the vascular supply is cut off now. Intracapsular fractures here. Now you can't think of any, revascularization. So the vascular supply is cut off already. So why do we want to operate this one earlier than later? Because the mortality rate of fracture neck of the femur is very high.
Yes, about 30%.
Yeah. So we have to do it within first 24 hours, or if not within first 72 hours or so. Otherwise, in Western countries, mortality rate is more than 50% because it occurs in elderly population. And if you correct the problem, then we can reduce the mortality. So that is the main reason that we have to go for early surgery. Okay. Can you hear me?
Yes, sir.
Okay. Dr. Bandhuji is there?
Yeah, I'm here. That's okay.
You want to ask some questions?
No, that's okay. Now, basically, are we looking at both X-rays? So he read only this X-ray.
This is the only intracapsular one I asked. Other one I didn't ask from them. So
Right,
probably
okay.
if you were.
Yeah, would you like to read the other X-ray also?
Bandhujiva,
Yes.
Ajit, just to clarify a small thing which
Yeah,
Ajit has just raised.
Yes.
What you are trying to say is now this patient is going to die because of the complication related to immobility.
Yes. Yeah.
Right?
Like
That is one thing. Yeah, mainly that is thing. So that there's the high mortality is peculiar to this site of injury. That is one thing. So maybe due to the complications itself. So that's why. So with this, that's why they say we have to do it early. So sometimes it can lead to deep vein thrombosis and then the
Pneumonias.
pneumonia, so on and so forth.
So considering the age and everything is
everything is a collective thing. Yeah.
Mobility plays a big role. You are right. Mobility plays a very big role.
Yeah. So by make them more mobile, you can significantly reduce these complications and the mortality.
Correct.
So would you like to read the other, the next X-ray?
Yes, sir. There's a,
Yes.
the X-ray shows the left side hip, and I can see a extracapsular fracture, probably at the pertocanthric fracture, and it's displaced and angulated.
Yeah. So you say it's a pertrochanteric fracture. Actually, you can describe fractures. No, you can see the lesser fragment, lesser trochanter separated. Also, you can see the. I don't know whether you can see when I use the cursor. I know this. Now these are great trochanter area. That's also separate. No, lesser trochanter. So this is the head. Yeah, yeah. Lesser trochanter and the greater trochanter, and then you can see the head and neck in one part, and then the shaft is down. So it is 4 fragment fracture, no? And according to your level, it's a kind of comminuted fracture. And also it's displaced. So it's a displaced comminuted fracture. You are quite right. It's in the neck of femur. It's in the extra. Why do you say it's extracapsular?
The capsule ends at the level of base.
Capsule attaches. Yeah. What's the level of? What's the line of capsule attachment?
The intratrochanteric line.
Yeah, intracanthal on that line. So this is clearly outside that. So what's the difference between the one that you discussed before and this? That is intracapsular and extracapsular. What's the major difference?
So the blood supply can be preserved in this.
Blood
To the
supply
head.
where? Blood supply to what?
Supply to the head can be preserved.
Exactly. Blood supply to the femoral head is preserved. So what blood supply is disrupted here? Now, what are the routes of blood supply to the femoral head?
From lateral and medial circumflex arteries.
That's further away. No? As they reach hip, reach hip.
Retinacular arteries, sir. And
yeah.
And the ascending nutrient artery.
Yeah, ascending nutrient artery means that comes through the, what is that? Intraosseous blood supply. The artery per se does not come there, no? It penetrates the bone, then it goes through the bone, no? Intraosseous blood supply. And then the reticular fibers, where do they come? Where do they lie here? At the fracture site, where do they lie? Where do these reticular?
Along the capsule.
Yeah, it gets reflected. And what's the other source of blood supply?
The artery of the ligamentum teres.
Yeah, exactly.
From the obturator artery. Yeah,
so here only the intraosseous side is disrupted. The other two, which is special, the reticular supply is intact. So we don't have to sacrifice the head in our definitive management, right? Okay, so quite rightly you told. Now, as a house officer, now when you're appointed, say this patient lands in your ward. Say you see them in the PCU, and then patient is transferred to your ward with the management mentioned before. Say the patient's leg is immobilized in a skin with skin traction, right? So the pain is reduced. Now the patient is there. What do you think that you should concentrate on? Now you know that what is the management of this then? Definitive management. Let's ask that first.
Surgical repairs.
Surgical. How do you manage this extracapsular fracture surgically?
With dynamic hip screws.
Yeah, basically there are various devices, but dynamic hip screws is the commonest one. Is there any place for non-operative management?
Yes, sir. If the patient is already immobilized, a non-weight bearing patient.
What is the place for? Why do you manage such patients non-operatively?
Because they might not be fit for surgery.
Why? Just because they don't work? If you don't operate, what is the result? We just mentioned.
Tardy union can happen and
high rate of mortality, no?
Yes.
That's what we decided just now, no? So even if somebody is immobile, if you want to save his life, then of course you have to operate. immobility per se may lead to a lot of complications, pneumonia, and a lot of things. No. So, of course, so non-operative management is there only for people who cannot be operated. They are not suitable for surgery. Under ideal circumstances, so they have to be operated,
Okay.
provided you can find theatre time in order to save the life. So actually nowadays there's nothing. No, you should manage them non-operatively because then because of very high rate of mortality, as well as there'll be gross malunion even if they don't die. So they will never be able to walk. Somebody will be walking. Generally, people with these fractures come when they walk about, when they fall and come. So you told quite right that surgical management is generally dynamic hip screw. So you don't know the details of them. But now I'll come back to my previous question. Say this patient comes to your board. Now you are the house officer. So you know definitely management is DHS. How will you manage this patient until your patient is operated? What are the things that you need to do in order to give a good surgical outcome?
So immobilize the patient, give adequate pain relief, and optimize the patient's condition
That's a
to
very
give,
broad word. I want details of that.
if
It has
the
a broad meaning, not the word. It has a broad meaning.
yes,
Optimization. That is the exact thing I am asking actually. Because this patient may not be operated now, set up within a day or two, may take few more days. So until such time, you have to optimize them and keep. Anyway, they need optimization. Commonly, these people are elderly people. They have a lot of, comorbidities. Yeah. So start from there. This is your role as a house officer.
Yes, so I want to optimize the hemoglobin level with adequate blood transfusions and optimize the PTINR by stopping if they are on discussing with seniors. After discussing with seniors, I'll have to either stop or bridge their warfarin therapies and other anticoagulants. And I'd also want to optimize their sugar levels if they are diabetic.
You're quite well there, but though your answering is not methodical, you are there. So, in other words, what you are saying is you will identify in the history what comorbidities they have, and then you will order relevant investigations and then treat according if diabetes that is the case, or if there's any renal issues or hepatic issues, you will attend to them. So that's one side. That is okay. So that is one side. What other things will you do? So that side is attended. What are the important things?
Patient's hydration status and
exactly.
The nutrition.
These people, elderly people, very vulnerable for dehydration. So, and since the time they arrive, probably maybe hours in the at home without eating and drinking, and maybe in the PCU in the ward. So they may. Why don't they like to eat or drink? These patients specifically. Why is their intake is poor? In other words.
So they do not want to get catheterized sometimes, and they don't
not
want to go.
Yeah, the one thing is actually you are right. They know if they think if they drink, they have to pass urine, so they avoid. They think if they eat, they have to do the go to the toilet. So to avoid that, they won't, because they know it's difficult to do that with pain. They avoid. More importantly, they can't eat and drink when they want unless somebody is given to them, because they can't walk. So they don't have access. So their dehydration level is very poor when they are admitted and after 2 hours. So you have to attend to hydration, this thing. So how do you improve hydration?
After educating
yes,
the patient.
You are quite right. Educating and get somebody to feed them enough adequate fluids by mouth first. But if necessary,
we'll have to go for
fine. What are the things that you want to do quickly?
The nutrition, sir.
Nutrition, yes, very good aspect. You have to attend to that. Then what are the other aspects? I told you this patient may take few days to to undergo surgery. What other likely things can happen? Now we have just discussed during these few days. You have to give advice, bystander or relative, or the patient himself, that he needs to turn and move his limbs. And especially he has to be propped up from time to time, despite having skin traction. Why do you do those things?
To avoid complications of being immobilized, like DVT and pneumonia, developing pneumonia and pressure sores.
Yeah, so in order to avoid pressure sores, you do whatever the log roll or mobilization of the other parts, and you arrange propping up, and then the chest physiotherapy to avoid pneumonia. And you told quite rightly, you have to take adequate measures too, because these have to be started immediately, not when they occur. So other thing is DVT prevention method. So the optimal, then you assess the other cardiac and all those things. So these things are very important. Unless you look after the patient until the time he is operated, by the time he comes to the operating table, he'll be dyspneic and he will be grossly dehydrated, and post-operatively he won't have a chance to live. So doing surgery is one thing, preparing surgery is very important.
Bandhujiva, can I interrupt you for a moment? What is the place of DVT prophylaxis in these patients? Do we postpone it till the surgery is being done, or
that is not actually necessary? We can give Clexane, although we don't practice. We can give Clexane, right? Enoxaparin, subcut enoxaparin is not a problem. 20 is not a problem. It's a small dose, no. Though we don't practice it, it's been given.
Okay.
So that is not a major issue. But we don't honestly give. We use other measures. We encourage tell the bystanders to move ankle movements, and the other things are stockings, right? So those are the things, and the patients have to be told that they need to keep moving their ankles, and hydration is very important in that prevent in all these aspects to prevent urinary tract infections and all those things. So I think basically we have covered this. These are the areas that I won't say. So the definitive surgery, and anything else that.
Ajit, I think, told them about the deformity they get with the fracture neck of femur.
Presentation, no? Yeah.
Yeah. So what are the other sort of deformities you get, Bandhujiva, with the hip problems, like dislocation of the hip? Will it
so
have
we can, if you want to touch on that, that's right. This is now typical. We mentioned external rotation of the leg with the shortening and kind of adduction.
Yeah.
And you can just simply, because commonest dislocation is posterior dislocation of hip. So when the hip is dislocated posteriorly, the leg head is directed posteriorly. So you can work out yourself in your leg itself when the leg is directed posteriorly, and then it will rotate internally. So as opposed to dispersion, the leg will be internal rotated, and also kind of adduction and internal rotated. So that's a classical position of posterior dislocation of hip.
Okay.
So
No, sorry.
Okay, sir. Shall we move on to the next one then?
Yeah, why not?
Okay, students, who is going to participate here?
Sir, I am, sir.
All right.
So what can you see here?
I can see above knee POP cast, which is starting from the groin, extended up to the metatarsal head, sparing all the fingers. and knee is slightly flexed, and the ankle is flexed up to 90 degrees.
So POP cast is a full cast or half cast?
Full cast, sir.
Okay. So what are the instances you use this kind of plasters like this way?
In the tibial and fibular fractures.
Tibia and fibula fractures. Okay, so what is the principle here in this above knee plaster cast?
When you get the fracture in the tibia, we have to immobilize the joint which is immediately above and which is immediately below, sir. So
Yes.
the knee and the ankle is immobilized, sir.
Okay, that is one thing. What are the other things? Why it is 90 degrees flexed at the ankle?
To take the proper alignment, sir.
That is not necessary for the proper alignment. Even the ankle is plantar fix also. That's also you can get the proper alignment. That's not a big issue. But why are we keeping the ankle 90 degrees position?
It is easy to the patient, sir.
Anyway, these kind of plasters you are going to keep for, rather long period, maybe a couple of weeks or maybe a month or two or something. So in that case, what's going to happen when you keep it plantar flex?
Patient might not be able to move at all, sir.
You get the quadriceps and the flexor contractures. You get the ankle contractures to prevent it, so that the flexors are maximally lengthened at this, not maximally, the significantly lengthened at this position, so that all the muscles are in a proper length in this case. Okay.
Yes, sir.
That is the reason. Why do we flex the knee for about 20 degrees or so? Why?
By extending the knees, flexors, extensors of the knee get further extended. So to relax the quadriceps, we have to slightly flex the knees.
Quadriceps are a little bit lengthened, no, in this position rather than relax. You understand?
Yes.
Okay. Okay. Now, so why putting water?
Actually, that's the maximum position. That's why you get the maximum length of the ACL and PCL, no? Ligament.
Yeah,
that's the reason.
That's right.
That's
Okay.
reason, yeah.
And so what? Before doing this plaster, what are the things you are going to achieve now? Now, suppose that there is a fracture tibia fibula, so you are going to put the plaster on. So, what are the things you are going to keep in mind putting this one?
So I would check for the any other wounds of the legs, and I would check for the any other fractures.
Leave aside the wounds. Okay. Now you see there's a fracture, close fracture. So what are you going to do now?
So I would initially clean the leg, then apply cotton wools, like 50% overlap.
No, I don't want the procedure. What are the things you're going to do for the fracture? I'm asking.
Fractures, I wanted to first reduce it, sir.
If you want to get most probably we'll do it under anesthesia. Otherwise, sometimes very rarely you do it without anesthesia also. You have to reduce the fracture. You understand?
Yes,
so in reducing fracture, what are the points you are going to consider here?
First about the pains, and about the anesthesia, and must take a proper alignment, sir.
One thing is alignment. You want to get the alignment. So one thing you have to consider about the alignment. Second thing,
whether it is corrected by a plaster cast or not, sir.
what about the rotation?
Yes, sir.
What is?
Yes. Uh,
What about the length? You are not going to check about it.
yes.
What is? You are not worried about the angulation of this reduction.
Yes.
Okay, so you have to consider all these things and then get the reduction, and in that position you have to put the plaster on, correct?
Yes.
Okay. As you said, I am not going to ask you how I'm going to put the layers like this and all. What are the things you have to maintain in this case, after putting the plaster or during the plaster? What are the things you are going to keep in mind?
So I would assess the pain of the patient, and I would ask patient to elevate the legs to reduce the edema, and I would educate the person regarding tight symptoms of tight plaster casting, swelling, and the excruciating pain, and I would advise patient regarding finger movements, and should consider about the other measures like DVT prophylaxis.
Okay, those things are correct. But apart from that, when you put the plaster on, it should not be very loose and it should not be very
Right.
tight. So you have to, keep that in mind, and it should be snugly, fit onto this thing, but without compressing in different places. And it should be uniform all throughout. Okay.
Yes, sir.
Okay. So you said that you give the correct instructions, elevate the leg. So what is the reason for elevation of the leg?
To reduce the edema, sir.
Reduce the edema. Reduce the edema. So it facilitates what?
Venous returns.
Venous return or tissue fluid return to the lymphatics. Okay.
Yes.
And last time I think we discussed the plaster complications, haven't we?
Discuss that in detail, no?
We discussed it, so we are not going to. So anything
Ajit,
you want to ask? Yeah.
Ajit, can I disturb you for a moment again?
Yes.
You asked them about sort of why do we keep knee 15 to 20 degrees bend in this plaster. Now, I remember sort of vaguely, now when the knee is fully extended, the knee joint is locked. So the movement of the femur move the proximal part of the tibia as well. So to overcome that, I thought sort of we flex at the knee.
Actually, the main reason for flexing is actually when you are immobilizing any joint, you have to have your ligaments maximally stretched, because you can. I mean, if you allow a ligament to shorten, it's very, very difficult to lengthen them again, even with physiotherapy. So you can actually remember the typical position that we use in the hand when you are immobilizing. We use all the interphalangeal joint extended and the metacarphalangeal joint flexed. Because the exact reason is that all the interphalangeal joint ligaments are maximally stretched when they are extended. And the ligaments at the metaphalangeal joint are maximally stretched when they are bent, flexed. So similar here also, the ligaments are maximally stretched in that position, especially ACL and PCL.
Right. Okay.
So
Okay, sir, we'll move on the next one.
yeah, go to the next one.
Okay, who's going to be the candidate here?
I'll ask few questions then. Who is this? Somebody ready?
Yeah, so I'd be answering.
So let's ask, what do you see in the X-ray? Read the X-ray as if you are reading in the exam.
Yeah, so there are two X-rays. The first one is an anteroposterior view of the right leg showing, and the B is the lateral view. So it's showing from the right side knee joint to the ankle joint. In the X-ray, I can see there are two fractures in the mid shaft of the tibia and the fibula. Both are oblique fractures and displaced partially.
Your initial reading and description is very nice, actually. You didn't, but fracture, yeah. If you can explain the fracture a bit more, that is very nice. You told it's a short oblique one in the tibia, no?
Yes, sir.
But almost, yeah, it's a short oblique one in the fibula also. So what are the things you said?
So two fractures, both are mid-shaft fractures, oblique, and partial displaced.
Partial displaced, true. But you can see some fragments in the tibia fracture, no? Can you see it? They have not separated, but about to separate.
Yeah, yes, sir. Yeah.
What is that fragment called, especially if it completely separated? Can you show that fragment, Dr. Pinto? On the AP beam, the butterfly-like piece, this is called butterfly fragment. It's common, and then go to the other side also. No. Like a butterfly, there's this. Now in the AP, you can draw a nice come like that and go down like that. Go down the other. No, like a butterfly. That's right. It's called butterfly fragment, a common term because it's a common fracture configuration. It's a common fracture pattern. So otherwise your fracture, it's a partial displaced fracture. I'm very happy. So my question next, if this patient comes to you with this, what you see in the other picture, what do you think is this fracture?
So it should be an open fracture.
Very good. Answer is it should have been an open fracture. Now, if this patient comes to you when you are the house officer in a hospital where there's no, say, PCU or anything, where the patient directly comes to the surgical ward and you are the house officer, he's after a motorbike accident and other major injuries, any life-threatening injuries, head injuries, cervical spine injuries, everything has been cleared. He's left with this. How will you look after this patient?
So the fixate is applied?
No.
Oh.
He's just, yeah. He's coming after this road traffic accident too. The rest is excluded by somebody. Just assume. And you are the house officer. He has met with an accident about 1 hour ago, brought by his friends in a 3-wheeler.
So I'll examine for the other associated soft tissue injuries, whether there are any associated nerve injuries and vascular injuries. And
no, don't mix up everything. Now you said first you examine the fracture itself and the wound. So now what are the things that you see in the wound? You want to examine in the wound.
The size of the wound.
Size.
And whether it is communicating with the fracture.
Okay, where it is, size, site, where it is. You have to draw a diagram. Where it is. Yes.
Site, size.
Because it can be on anywhere around, right? Anterior, posterior. Okay. Site, size, and then
shape and the
yeah, you can draw a line. It's yeah. What are the things?
and the depth of the wound,
Depth. So why do you want to see the depth?
whether it's communicating with the fracture hematoma.
Exactly. Whether it's a superficial wound or whether it's a, you may not be that easy to see, but that is something that you must look for. Whether this wound is deep or superficial. And deep, it is communicating with the fracture site. Okay. What clues will you have if it is communicating with the fracture site? Sometimes
maybe bones are visible.
bone is visible. Very nice, yes.
Maybe it's bleeding.
Yeah, if the fracture hematoma is leaking, then you know. But otherwise, if it is deep wound, especially on the muscular side, rather than the shin, anterolateral, anteromedial side, then if it's deep, you are not sure. Okay, fine. What else do you look for in this wound? These are things you must document in the diagnosis, in your BHT, right? And this comes under what you call local examination, right? You quite right. It said no degree of soft tissue injury. If you see a lot of soft tissue ripped off here and there, so you can say, oh, it's crushed. You can say crushing or bad soft tissue injury. What else?
Foreign bodies.
Yes, contamination. The word is degree of contamination. Anything else? If you are good, just whether the bone that is jutting out is badly stripped off periosteum. So remember, these have to be examined and looked for and documented in your BHT. Why is this relevant?
It will decide the further management and
based on
the open or a closed fracture.
No, it is open fracture. Now don't back to closed fracture. Now we are talking about open fracture.
And it can cause infection.
You are right. Now let's come this way. Now we have gathered a lot of information. Ultimately, based on this, we decide whether there's a thing called Gustilo classification. Have you heard of it?
Yes, sir.
You don't have to know it in detail, but I think even as medical students, you should have heard it. And yes, so these are the factors based on which we are going to classify this fracture, whether it's Gustilo 1, grade 1, 2, 3. And this classification has a very prognostic value, right? So that is why we gather this information purpose, because all the, as you quite right said, these factors, if these factors are bad, they predispose to infection. And there are a lot of other complications. And these factors will make us, think about other, surgical options. So that is why we study the wound in detail. Then come to the other areas that you talked, your peripheral nerve vascular injuries. If you can assess tender injuries, whatever things that is, you can assess and document. So that is done. Right. Now the assessment is okay and all. At the same time, you can see whether it's compartment syndrome, but it's too early. I told about 1 hour ago, no? The patient, but I'll give an idea about the assessment of the muscle and those, the compartments also. Okay, what else will you do now? Now we have assessed.
So now the fracture should be managed. So in the management, initially the fracture should be reduced. And
no, wait. Now you are not. Are you going to do it there? Are you going to do the reduction? What will you do? I'm asking you are the house officer. You are in the ward. What are you going to do now? You have assessed it.
And do investigations, imaging, and
I want actually the investigations could mean anything, even CT scan, MRI, all those things. Investigations, imaging could mean, investigation could mean anything. Don't tell those things. Tell specifically what you do to him. Now we have mentioned everything very well. You are the house officer. He is shouting in pain. This man.
So the painkiller analgesics should be given.
Okay. And you give analgesic. Ideally, you must mention what you give also, right? You must with doses.
So
okay, leave that aside. Okay, what else to make it
and if there is bleeding, the bleeding should be arrested.
Arrested by
putting pressure.
Yes.
And
How do you do it? How do you do?
By putting a sterile pack on
course. Yes, and you apply. Get somebody to keep it pressed, or you can put a bandage. Okay. What else will you do?
And the wound should be cleaned.
How do you clean wound? It may not be that is do big cleaning, no, in the ward, but your attempt is good. How will you do that now? It looks horribly contaminated from outside, like a lot of mud and everything. Yes, I mean you can't leave that aside. Patient is taken to the theater maybe after 6 hours or so. Then you can use some sterile gauze, saline, and you can use some analgesics, something like pethidine, and just wipe them out then and there, because you don't want to leave a wound full of mud and everything until so you can do that little bit. But before that, what will you do? Before you do that, you give analgesics. Then what do you do next? There are two things nowadays I recommend. One thing, you must take swab for culture. That is very important. We don't know what it has been contaminated with, so you must take swab. And secondly, a lot of people recommend nowadays you have phones to take a photo. The simple reason is, otherwise every time you are going to clean this up the way you can, then cover with sterile gauze and keep it. Otherwise, when everybody comes, you have to open the wound and show. That is not considered to be very good. If you have taken a photo in different angles, then that person can get an idea what the wound is like. So then what will you do next? You have given analgesics. Now you have basically attend to the wound to the degree that you can do in the ward. What else?
Now it should be stabilized.
How will you stabilize it?
By
a step that should have been done a little earlier. Yes. What is that?
I can put a splinter.
You are right. You must put a splint. That is very important. That will, step should come a little earlier. As soon as you finish your examination, get somebody to apply the splint. That is important. That way, immobilization will reduce pain, and it will further reduce, because with the movement of the patient, you can, he might damage soft tissue more and more. So that also will be prevented. Okay. So what will you do next? What is another important thing? The patient says the theater is going to be, he will be taken to the theater 6 hours later.
Keep the patient nil by mouth.
Exactly. So you keep the patient nil by mouth according to the time that you can operate. And before, okay. So what is an important thing that we do in open fractures?
Start antibiotics.
Why do you talk as if you are talking with a lot of doubt? So how will you answer? As if you are in doubt, you talk. So will you give antibiotics or not?
I give antibiotics, sir.
Is it recommended or not? Is it recommended to give antibiotics for open fractures?
Yes, sir.
When is that? When should it be given?
After taking the culture.
Exactly. That's the exact answer. After taking culture, you must start antibiotics. So what antibiotics? Because you have to tell the nurse.
Antibiotic which covers both gram-negative and gram-positive broad-spectrum antibiotic, like coamoxiclav or metronidazole.
Oh, wait. Why did you put metronidazole? Now you came all the way. So far, very good. But why do you put out metronidazole all of a sudden? Or broad-spectrum antibiotics like coamoxiclav and then metronidazole, right?
No,
that's not
sorry.
What is the other one? Cephalosporin, no? We use commonly either coamoxiclav or cephalosporin. You are quite right. So we target Staph aureus and sometimes Staph albus also. But if the degree of contamination is very bad, like Gastilo 3, then of course you are advised to add a gram-negative cover also, right? Thirdly, if you know the site of this got contaminated, if there was fecal matter or some other contaminated by soil or any other dirt matter, then you are advised to add metronidazole also, depending on the information that you gather, right? But generally for gastro 1 and 2, usually they say the broad spectrum antibiotic is enough. That's the usuality. So you have given antibiotics, you have done all the basic work. Then you prepare now of course you keep the patient fasting as the sprint analgesics, and then you prepare him for further management. You have bled a lot, and if you need to arrange certain things, assess and do that. Anything else, Ajit? Do you want to add anything to this management?
I think it's all covered.
And you can go to the external fixator part.
Yeah, go to the external fixator part. That's normally we ask in the short cases and all.
Yeah.
Ajit,
you can do.
Okay. Now, so why do you call this external fixator?
Because it's placed outside the body, sir.
So the fixation has been done outside the body, but there are inside pins also, no?
Yes, sir.
Okay. So what are the purposes of this using these external fixators?
It is used to immobilize after the reduction. So
one thing is the stable immobilization, okay.
And
what is immobilization is one thing. Second thing is
it facilitates the wound care.
If it is if the wound needs a prolonged care, so it facilitates. So accessibility to the wound and management of the wound is easier than with the plasters and other things. Correct?
Yes, sir.
Okay. So say it clearly like this. Okay. And what else?
And it also allows the joint movement, so there won't be any muscle wastings. And the
proximal and distal joints will be able to move. So good. Okay.
And compared to POP cast, it is lighter in weight and comfortable for the patient.
Okay.
And
does it maintain the length?
Yes, sir.
It maintains the length of the bone as well as the muscles. Okay. What is? So what are the other purposes of using this? So one thing as sometimes less commonly we can use it as a definitive fixation method also. Okay. You can hear me?
Yes, sir. Yes, I can hear.
Okay. So now you know the Bandhu, anything you want to ask about this?
Actually, I mean, if you want to discuss about these external fixators, there are various varieties. I don't think that you need to know anything about those things. If you know that these are external fixators, from my point of view, more than enough. If somebody can describe, there are various types, uniplanar, multiplanar, ring. I mean, if you have seen, I assume that you have seen them in the world. So remember them. But well, we won't ask them in the exact, even if you ask, don't worry, we won't fail you on those things. Those are beyond your level. No? But one thing I forgot about open fractures, actually nowadays we don't see, but we used to see a lot of gunshot injuries. We used to see.
Okay, and anyway, now, so enough for that part. So what are the problems you can get from these external fixators? Like
So the external fixator can it can give rise to pin site infections.
Yeah, pin site infections. How do you identify the pin site infections?
There will be some pus coming out from the pin sites, and
Maybe discharge or pus coming out. Oh, okay.
And the pin sites will be loosened.
Maybe the pins are loosened. Oh, and what else?
There will be erythema and signs of inflammation around the pin site.
Oh, inflammatory signs. So if you suspect this kind of complications, discharges or something, how do you manage this one? How to prevent those things?
The prevention.
Yeah.
So the pin site should be kept clean and
daily cleaning of the pin sites with what? With antiseptics and the saline. Okay. So if you know this stuff about about the external fixators from your point of view, I think it's quite adequate. What do you think, Bandhu?
Yeah, that's more than enough. That's what I want to. Somebody just posed a question: should the tetanus this thing should be given? Yeah. We should have mentioned that. That's another thing that we should give, right? You have to check their tetanus immunization history and then give the tetanus toxoid appropriately, right? So somebody posed that question just now. The other thing I want to ask about: do you all know by any chance the Gustilo classification?
Yes, sir.
You know, I suppose you should know that there are 3 grades and what these 3, because that's not a big thing. What I want to tell before was that now commonly we used to see a lot of these gunshot injuries. Even if the wound is very small, in the case of gunshot injuries, there's a fracture, even if the wound is less than 1 centimeter. Now they fall under category of, Gustilo-Anderson grade 3. Remember, actually grade 3B, 3B. So that is something that you should remember. So gunshot injuries are considered heavily contaminated injuries with a lot of disruption of soft tissues inside. So irrespective of the size of the wound, which may be even less than 1 centimeter, gunshot injuries causing open fractures are considered Gustilo-Anderson grade B, grade 3B, right? I think we have covered most of the things, I presume. External fixator, in external fixator, we can let in by callus, but when there is
Okay, sir.
I think basically we have covered.
We have covered. There are a few questions some people are asking.
Yes.
So external fixators are. I can't read that. Pinto, can you see those questions?
I can't see.
Dr. Pinto?
I can't see, sir.
All right. In external fixators, can we let it heal by callus formation? But when there is internal fixator, doesn't it interrupt formation of callus? No, internal fixators actually, they don't interrupt callus formation. Secondly, external fixators, sometimes they allow callus to form, but generally external fixators are considered basically for management of soft tissues. What we generally do, because it's a bit cumbersome to keep them outside also, no? Generally, once the wound management is over, we remove them. But there are exceptional circumstances. We use external fixators to get the fractures to heal. So external fixators are applied to open fractures or closed fractures, generally for open fractures, right? There may be exceptional circumstances where we use external fixators for closed fractures, but that is not your level. How do you manage pin site infections? So we told regular, no, you keep them clean with saline daily, and then betadine dressings, you change them daily. But if the pin site, actually the pin sites badly get infected, that's an indication for removal of the external fixator, and think about any other At least that particular external fixate, the pin should be removed and then move to another place. Those are the questions I've seen.
Yeah,
Okay.
I think we can call it a day, sir.
Yeah.
Sumu sir, are you there? All right. Anyway, thank you very much, Ajit sir and Manduji sir. Thank you very much for your support. I think in the future also, if we have something like that, you will be rendering us your support.
Definitely. Thank you.
Okay, sir. Okay. Thank you. Good night.